Okay. Hello, good evening. Today is our discussion about hepatobiliary. We will discuss together eMRCS questions and answers as usual. Okay, so let's start with ladies first. Okay, Dr. Shi, Dr. Zaina, Dr. Az, Dr. Abu Yazid, okay?
A 53-year-old man is referred because he was being investigated with an ultrasound scan for gallstone disease. While a large gallstone was seen in a thin-walled gallbladder, a lesion was also seen in the left lobe of the liver. On MRI, this has been categorized as a 6 centimeter hepatocellular adenoma. What is the most appropriate course of action? Maybe surveillance with ultrasound and measurement of alpha-fetoprotein at 6-month interval.
Is your answer?
With surgical resection, C. Final answer, C. Surgical resection.
Okay, anyone wants to add anything or another answer can send in chat. Okay, so Dr. Abu Yazid will not share. Okay. Surgical resection, yes, yes, exactly, Dr. Zaina. We have an old man with a tumor or a mass in the liver, especially in males. We know that hepatocellular adenoma can happen in young or middle-aged females taking oral contraceptive pills. This is one of the side effects, and size is almost smaller and can be followed up. But when it's large size, like 6 centimeters, we have also to remove. But in old male, malignant transformation is a high risk, so we have to remove it. Okay. Next question, Dr. Zaina.
Okay. 55 years old accountant has jaundice and a temperature of 39. He is known to have gallstones. Blood cultures have grown gram-negative bacilli. Imaging show a bile duct measuring 1.2 centimeter in diameter. What is the best treatment option? BTC and stent, BTC and drain, ERCP and stent, MRCB ultrasound.
What do you expect this patient to have?
Well, obstructive jaundice.
Jaundice. Jaundice, fever.
Cholangitis.
And positive blood culture. Obstructive
ARCB
jaundice.
ARCB and stent.
ARC.
في هنا في يعني high grade
Ascending
fever.
cholangitis.
ده indicate cholangitis. So we need to relieve the condition. We will do ARCB and stent.
Okay, this is a picture of like Charcot striate, jaundice, temperature. I think there is pain because the patient has gallstones and the bile duct measuring 1.2. Is 1.2 is normal?
لا كده large diameter مفروض أكتر حاجة
That
8.
means 0.8 maximum. Okay, so that means that there's on obstructive jaundice with stool. 0.8, okay. So this man present with Charcot's triad, mostly with Charcot's triad because fever, jaundice, and mostly will have pain because of obstruction. And the patient has a history of gallstones. So you will have to do ERCP, urgent ERCP, and the drainage of the sphincterotomy and the drainage of the obstructed bile through removal of the stone. If you failed doing this, what's your next step?
BTC.
BTC and the drain, exactly. You'll go for percutaneous transhepatic cholangiography. Exactly, Dr. Abu Yazid. So because you couldn't reach the sphincter, or you couldn't cannulate the common bile duct, or you couldn't remove the stone, so you'll go for PTC, which is done with ultrasound or CT or MRI. Undergyned, yes, mostly with ultrasound. I did see it before with MRI. So that's our management in obstructive jaundice with patient with jaundice. Okay.
Okay.
Next question, Dr. Ahmed. Unmute yourself.
A 65-year-old man is admitted with jaundice, and investigations demonstrate a carcinoma of the pancreatic head. An ERCP is attempted, but the surgeon is unable to cannulate the ampulle. What is the best course of action? Webber's procedure, laparotomy and fournital hepatogynostomy, percutaneous transhepatic cholangiogram and drain, external beam radiotherapy, laparotomy, and duodenoscopy. I think C, percutaneous transhepatic cholangiogram and drain.
Okay, Dr. Shi C. Dr. Abu Yazid C. Dr. Okay, yes, exactly. But we said whatever the obstruction, and we couldn't cannulate, and the patient is critical, like jaundice, we know whatever we can. This is still operable or not operable. You have to treat the critical condition, which will actually lead to patients' morbidity and mortality. And then you will go for your further investigation to detect the staging, and if the patient is operable or non-operable, at least you want to relieve the jaundice to complete your investigation. So the first scenario was stone, the second scenario was a mass pancreatic head. Okay. Next question. Okay, Dr. Shi again.
A 67-year-old lady is admitted. A 67-year-old lady is present with jaundice and abdominal pain. Her investigation show a dilated common bile duct, a carcinoma of the pancreatic head compressing the pancreatic duct. Her liver contains bilobar metastasis. What is the most appropriate course of action? So, insertion of endoscopic, insertion of endoscopic biliary stent and consideration of, it's A, insertion of PTC and palliation.
Okay. Different answer. Dr. Fad the same. Dr. Zainab, Dr. Fez, what do you think? Dr. Zainab, has a tracheal endoscopic. Biliary stent has a ERCP. And then chemotherapy. Okay, exactly. This patient has bilateral liver metastasis. This means this patient is
inoperable.
Metastasis, not fit for surgery, so we'll do stent only.
Stent, how you go for the stent?
The
ERCP,
ERCP.
give chemotherapy.
Yes.
مش موجودة في الاختيارات. مفيش
لا
ERCP.
موجودة هي في الاختيارات. لا
Endoscopic
it means
attempt.
endoscopic biliary synthesis and ERCP. Doctor, she was right in the first, and then
I thought maybe because of the pancreatic head carcinoma, the ERCP maybe would not pass, but actually in the first instance we should always try the ERCP, and if it fails then we go for the PTC.
Yes, you can't go for PTC without
ERCP
a trial
first.
for ERCP.
The ERCP, yes,
okay, whatever the palliation is with chemotherapy, radiotherapy, even surgical palliation or just supportive treatment, you have to go for ERCP first. This is the first step through the normal pathway, because PTC is unstable stent and it is frequently dislodged and frequently change its direction and fell down from the patient. So ERCP and the stent will be more stable for this patient, and you go for palliation. You can't go for pancreatic duodenectomy or resection of the primary lesion, because you can't resect the primary lesion while you have secondaries in liver. The only condition you can remove the primary lesion that you don't have any other secondaries. Okay, and also the same, if you have one metastasis and you want to remove, it's you can't remove without removal of the primary tube. Okay, next question, Dr. Zaina.
Okay. 43 years old lady present with 24 hours history of generalized right abdominal pain. On admission, she is septic and jaundiced, and there is tenderness in the right upper quadrant. What is the most likely diagnosis? Cholangitis. الاختيارات cholestatis, cholangitis, gallbladder emphysema, gallbladder abscess, liver abscess. It is cholangitis. The patient has fever and pain and jaundice, Charcot striate.
Okay.
Cholangitis.
Yes, cholangitis. Cholestatis can't give us jaundice. Okay. And sometimes can't give us septic shock, because just it will be rarely to give septic shock. But cholangitis, because it's spread inside the liver, can cause us this. Gallbladder empyema is the same, gallbladder abscess the same, liver abscess the same. All these causes can't cause jaundice except for cholangitis. Okay, Dr. Ahmed.
A 23-year-old lady is admitted with right upper quadrant pain. On examination, she is tender in the right upper quadrant. Imaging shows signs of acute cholecystitis due to gallstones. The common bile duct appears normal. Liver function tests are normal. What is the most appropriate course of action? Laparoscopic cholecystectomy during the next 24 to 48 hours. Open cholecystectomy during the next 24 to 48 hours. Laparoscopic cholecystectomy laparoscopic cholecystectomy during the next 24 to 48 hours.
Okay.
Open
You have a different answer. Dr. A.
laparoscopic. هي laparoscopic أول واحدة.
Dr. Yazid A. So it is not laparoscopic cholecystectomy after 3 months. It is not open. It is not after 5 days of intravenous antibiotic. Okay, exactly. This is laparoscopic cholecystectomy after, during the first 48 hours. You have 2 schools, by the way, in acute cholecystitis. One school tell you that you have to manage the patient within the first 24 hours, 48 hours up to 72 hours. By the way, some in the first 3 days. And see, this is the golden time for laparoscopic cholecystectomy, because the adhesions here is fibrinous adhesion. Okay, but after the third day, the fibrinous adhesion will be converted to fibrous adhesion. Okay, so you'll do laparoscopic. We actually don't do open cholecystectomy unless we fail to do laparoscopic cholecystectomy. We always start with laparoscopic. Once in the laparoscope, you start to find it is difficult to do, you will go for open cholecystectomy. So laparoscopic is the best choice answer. Okay, next. If anyone wants to share, just raise a hand. Okay, go.
An 82-year-old lady is taken to theater for a common bile duct exploration. She has a stone impacted at the distal aspect of the common bile duct, and despite best efforts, it proves impossible to remove it. What is the best course of action? Close the bile duct over a T-tube and arrange for a stent to be placed. Undertake a choledochoduodenostomy. Arrange for a repeat ERCP. Construct a hepaticojejunostomy. Bypass the gallbladder into the jejunum. I think undertake a choledochoduodenostomy.
Okay. The answers. Doctor has A, Yazid A and B. Dr. Zena B. Okay, so how old is this patient? This patient is 82, old age, and you are already in the operation and you are doing opening. You are opening the bile duct, common bile duct. And the stone is hard to remove surgically. So it will be hard to remove by ERCP. Okay, putting a T-tube and arrange for a stent for the patient is not logic, because the patient you will not be able to pass a stent as you couldn't remove it surgically. So it will be difficult to remove it, to put a stent. Arrange and repeat ERCP, the same concept. Construct hepaticojejunostomy. No, it's very advanced operation, hepaticojejunostomy, and was not done except you are damaging all. If you lost all the common bile duct with the confluence up to the hepatic plate or hepatic bed, so the only thing you can do here, hepaticojejunostomy, but you have an intact common bile duct, so you can use it for an anastomosis and bypass the gallbladder onto the jejunum. Also, it is not a logic option for this. So the only one is undertake choledochoduodenostomy. Anyone can't understand this and what is mean and why we did choose this? Is it clear?
Yes.
Okay, as you couldn't go it for laparoscopic, for surgical, it's difficult to pass an ERCP. So A and C are wrong. And construct hepaticojejunostomy, this is an operation we do when we have no stump. We have no stump to make the anastomosis. That means we lost sometimes in some tumors or in some injuries that you completely cut the common bile duct up to the confluence. So you just have the hepatic plate or hepatic bed. So you can just put the jejunum to the right and left hepatic ducts together, make anastomosis, which is called hepaticojejunostomy. and we don't use, and it is not a common practice to do gallbladder to the jejunum. Okay, we always anastomose the main way, common bile duct or the hepatic duct to the duodenum or the jejunum, according to the case of the patient. Okay. Next question, Dr. Shi.
A 53-year-old alcoholic develops acute pancreatitis and is making slow but reasonable progress. He is troubled by persisting ileus, and for this reason, a CT scan is undertaken. This demonstrates a large pancreatic pseudocyst. This is monitored by repeat CT scanning, which shows no resolution, and he is now complaining of early satiety. What is the best course of action? So we could go for cystogastrostomy, maybe an elective cystogastrostomy.
Yes, pseudocyst, pancreatic pseudocyst.
Exactly. This is the only solution we do for a pseudopancreatic cyst when develops for a patient, and which show no resolution and is now complaining of early satiety. This is monitored by repeat CT scanning, which shows us. Okay, management of this is, we will do, by the way, we'll do elective cystogastrectomy. Yes. Did you elective? Yes, this is not an emergency operation. This is not obstruction, as the patient is complaining from early satiety. So we'll do elective cystogastrectomy. Okay, management of pseudopancreatic cyst. Pseudopancreatic cyst is very common to happen for patients with acute pancreatitis. It always appears from 4 to 6 weeks. And it takes about less than 2 to 3, maximum 4 weeks to be resolved spontaneously. Less than 4 weeks. Okay? But we have what's called the rule of 6. Rule of 6 says if it is more than 6 weeks and if it is more than 6 centimeters in diameter, so we should interfere to do surgery for the cyst, and the most common surgery we do it is cystogastrectomy. Okay, cystogastrectomy. Do you understand what is cystogastrectomy?
لا أنا ما أعرفش معناها إيه. بيفتحوها على ال
البوستيريور بتاعت الستومك. اوكي يس، يعني انا عندي
لو كانت انفكتد بيتعمل لها external drainage.
انا لو هاخد sagittal section في البادي، دي عندي الستومك وعندي السيست عامله كده في الستومك في البوستيريور ابدومينال وول، ولا اتخيل ان دي الستومك مثلا. تمام، وادي البنكرياس وراها، بنكرياس وراها وعامله لي سيست. باجي بروح اعمل ايه؟ بروح فاتح الانتيريور ابدومينال وول بتاعت الستومك. تمام، واحيانا بتتعمل اندوسكوبيك كمان. اجي البوستيريور راح فاتحها واروح فاتح فتحه كبيره هنا. تمام، واروح مخيط الوول بتاعت السيست، اخيطها في الوول بتاعت الاستومك من ورا، واخلي الاتنين بقوا ايه، دي كلها بقيت one pouch. This is called cystogastrostomy. All the contents بتاعت الcyst will be drained inside the stomach. Okay, this is cystogastrostomy. يعني just put in mind انت بتفتح posterior wall بتاعت الاستومك. Okay, whose turn? Dr. Zena or Dr. Az?
Okay.
Okay, Dr. Zena go and then Dr. Az.
Okay. 40 years old woman admitted with abdominal pain. She has suffered from repeated episode of colicky right upper quadrant pain. On examination, she is pyrexial with right upper quadrant peritonism. Her blood test shows a white blood cells of 23. However, the liver function tests are normal. An abdominal ultrasound scan shows multiple gallstones in thick wall gallbladder. The bile duct measure 4 millimeter. What is the best course of action? Administration of broad spectrum IV antibiotics and perform a delayed open cholecystectomy in 3 months. Arrange a radiological cholecystectomy, cholecystomy. Undertake a laparoscopic cholecystectomy. Undertake an open cholecystectomy. Administration of broad spectrum IV antibiotics and perform delayed laparoscopic cholecystectomy in 3 months. هنا بيتكلم عن case of acute cholecystitis. So the best protocol in treatment undertake a laparoscopic cholecystectomy early.
Which one?
C, under laparoscopic cholecystectomy.
Okay, so this is a case of acute cholecystitis.
Acute acalcular cholecystitis.
No. Multiple gallstones in a thick-walled gallbladder.
Calcular cholecystitis.
Okay, why thick-wall?
From inflammation.
Chronic inflammation.
Edema of gallbladder. Yes, this is edema of gallbladder and the stones. What happened? Scenario that a small stone, multiple gallstones is more dangerous because some small stones may pass through the cystic duct, obstruct the cystic duct, so obstruct the secretions. So happened what's called acute cholecystitis or empyema of gallbladder. You will find multiple gallstones and you'll find thickness of the wall due to inflammation and edema of the wall. And the patient will have septicemia or high TLC and fever. Okay, so we set the protocol here. We go for laparoscopic cholecystectomy, and we don't wait in the first 48 or 72 hours, and we don't wait these other schools. Sometimes we do that. We make what is called interval cholecystectomy and go for what's like mimics oceanal sharing for appendicitis, and we go for conservative treatment and then open the patient after 3 weeks or something like this, up to 3 months. But here, the protocol in the US and in UK, that you go early laparoscopic cholecystectomy.
But
okay,
the
next
question. Dr. Rami, the question confuses us because it says repeated episodes of colicky pain and it doesn't say how long before.
Repeated episodes, she is pyrexial, was right. Repeated episodes, but he didn't say repeated fever.
Elevated white blood cells.
Of upper quadrant pain.
And the acute
Repeated
inflammation.
episodes means there is passing stone, because the pain will happen when the stone starts to obstruct the heart vein or obstruct the cystic duct, and this will make the pain.
Okay.
Okay, but now the patient is pyrexial and her blood cyst like this, and her liver function are normal. Liver function are normal, so she is not late. Still, she is not late. Okay.
Okay.
That's all. Okay, next question, Dr. Rez.
A 48-year-old lady is admitted with attacks of biliary colic, and investigations show gallstones. A laparoscopic cholecystectomy is performed. The operation is technically challenging due to large stone impacted in Hartmann's pouch. Following the operation, she fails to settle and becomes jaundiced and has bile draining into a drain placed at the surgical site. What is the best course of action? Arrange an ERCP and
Okay, what
take a
happened for this
laparotomy.
patient?
Injury to the bile duct. So, injury to
Okay.
bile
Bile
duct.
duct injury.
Yes. Yes.
Arrange
So
ERCP and take a
what will you do?
laparotomy. Arrange abdominal ultrasound. Arrange MRCP. Arrange abdominal CT scan. Arrange an ERCP
For
drainage, stenting and drainage.
yes, Carpenter's D. Dr. Shibi. So this is a challenging operation when you go for Dr. Zena A. When you go for a laparoscopic cholecystectomy and it's difficult or challenging and you can't proceed, you can convert the patient for open cholecystectomy. Otherwise, if you are going to complete laparoscopically, you may do hazardous results through injury of the duodenum or the common bile duct or the liver bed or any other injury, because this is risky abdominal operation. What has happened here is that the patient, the doctor completes the operation, and after the operation, he sees bile leakage through the drain, which means the patient has a bile duct injury. Okay, so what we do here, we do an ERCP and we put a stent bypassing the injury. Okay, and as there is open pathway and there is no obstruction, the injury mostly will close spontaneously if it is a small injury. Okay?
Okay.
So we are this scenario because assumed bile duct has been damaged. So ERCP is the most appropriate investigation, and which can be diagnostic. And if there is big, some people can go for a laparotomy and suturing, or you can, it allows you to put a stent. Okay, to put a stent to save. Okay, with a diagram. Okay. This is the gallbladder. This is the cystic. This is a common hepatic. And this is the bile duct. And this is whatever, this is the duodenum. Okay. This is the duodenum. What happened here is that I'm going for a challenging operation and it is difficult. So while cutting here, okay, I make an injury here, here, here. And after the operation, I found a bile leakage from the, I found a bile leakage. And so, I found a bile leakage. What will I do? I will go with an endoscope. I'll go with an endoscope and I'll go and make an ERCP cholangiogram and then see what is the size of the lesion. If it is small, I can pass a stent here. Okay, just to make this pathway open and patent. So I decrease as any fluid in the body goes through its normal pathway, provided there is no obstruction and there is no infection. So the bile will go its normal pathway through the CBD till closure, spontaneous closure, or further management through a hepatobiliary surgeon or a hepatobiliary center, because CBD injuries or bile duct injury, you have to refer your patient to a hepatobiliary surgeon or through a hepatobiliary center, and you don't, it's preferred not to do it by yourself. Okay, it's clear? Clear?
Clear.
Okay. Okay, next question. Who on Dr. Basharat want to share? Dr. Basharat?
Assalamu
Okay,
alaikum.
Dr. Shi. Dr. Alaikum Assalam.
A 73-year-old lady undergoes a laparotomy and a gallstone ileus is identified. The gallbladder itself is densely adherent to the duodenum. What is the correct course of action? Milk the gallbladder stone into the colon and leave the gallbladder. B, remove the gallstones from the small bowel, resect the gallbladder and close the duodenal defect transversely. Remove the gallstone from the small bowel and perform a subtotal cholecystectomy. Then D, remove the gallstone from the small bowel and undertake a cholecystectomy. And the E, remove the gallstone from the small bowel and leave the gallbladder alone. I will go for the last option, is the remove the gallstone from the small bowel and leave the gallbladder alone, because this gallstone can occlude the ileocecal junction, which can cause obstruction. So we have to remove this gallstone, and gallbladder can be kept alone.
Exactly, and most of you answered E. We have to remove the gallstone and leave the gallbladder alone. It needs illustration. Anyone want to understand, or it's not clear? Just raise hand or write in chat. Okay, why we leave the gallbladder? Okay. What happened here is the gallbladder stuck to the duodenum, and a stone passed till the ileum at the colon. Okay. The stone impacted here. Okay. So what we are going to do here, we are going to make a proximal. We are going to make a proximal incision, proximal, not distal. Okay. And milk the stone a little bit back. It is not so far, just behind the stone, and milk it, because here the tissue is edematous from the obstruction. Okay, and if you make any trial to make it at the same site, it may be difficult to heal, maybe a weak wall and something like that. Just go for a healthy proximal site, and as the stone passed forward, it can be passed backward, and you remove the stone. Okay, this we finished from this. We finished from this. Come here. We have now a complete. We have a complete patent we have a complete patent here fistula or an junction between the gallbladder. Why I just disturb this normal anastomosis and normal connection between the gallbladder? So if you want to just dissect this cholecystectomy, you will leave a big defect here, which will be difficult to suture, and stricture may happen, fistula may happen, and many complications will happen here. So what happened here? The gallbladder stuck with the duodenum and they become one organ. So you will leave it without intervention. So this is a normal fistula, like sometimes we do colodicoduodenostomy or a hepaticojejunostomy or something like this. So this is normal happened, amalgamated or a stuck gallbladder with the duodenum and make the fistula, and they be a normal pathway. So just forget it and leave it. Better than you can go for more hazardous if you try to make any intervention through the duodenum itself. Okay, clear? Okay, Dr. Shi.
Which of the following is the most sensitive blood test for diagnosis of acute pancreatitis? Serum lipase B?
Yes, exactly. Serum lipase is the most specific and most sensitive for diagnosis of pancreatitis. Second one is like amylase, and amylase is not specific because it can rise in many other conditions in the body. So the most specific is serum lipase. Okay, and by the way, serum amylase rise early, and so early and late, it gives exactly short life. So it is in the first 24 hours, it will give us wrong results, and also after 2-3 days will give us wrong results because it arises late and goes early because of its short life. But lipase is specific for pancreatitis. Next question, Dr. Zaina.
Okay. 72 years old man undergoes distal gastrectomy for carcinoma of the stomach. He present with jaundice, approximately 8 months post-operative. Ultrasound of the liver and bile duct shows no focal liver lesion and normal caliber common bile duct with intrahepatic duct dilatation. What is the most likely explanation? Perihilar lymphadenopathy, Fitz-Hugh-Curtis syndrome, Gilbert syndrome, Risi syndrome, gallstones. أنا بصراحة مش عارفة الفيتز-هيو-كيرتس syndrome ده إيه يعني، بس ممكن بالإكسبشن كده تبقى perihilar lymphadenopathy.
انت كنتش معانا المحاضرات اللي فاتت؟
لا أنا فاكرة أنا سمعته بس مش فاكرة هو إيه يعني.
Okay. What's the answer? A. All said A. Yes, exactly. You have a cancer stomach and you removed, and the patient comes with jaundice, and you just go for the liver and bile duct. The liver is clear, common bile duct is clear, and intrahepatic bile duct dilatation. So what level you will have here? Obstruction. This is perihilar lymphadenopathy. Okay, you went for the gallbladder. Okay, and you find this right and left hepatic, common hepatic, cystic, gallbladder, common bile duct. Okay, the patient come, and there is here is the lymph nodes at the porta hepatis. And you went for the patient come with jaundice, and you go for the you make your investigation, and you found the liver. The liver is normal. The CBD is normal, not dilated, but you found dilatation in the intrahepatic bile ducts. So where is the obstruction? So if the obstruction was here, okay, with a stone or Mersey syndrome, because Mersey syndrome will make obstruction here, okay, you will find the common bile duct is dilated, but just the intrahepatic biliary ducts are dilated because this enlarged lymph nodes will obstruct the right and left hepatic ducts at the porta hepatis and will cause dilatation in the intrahepatic, but post-hepatic all, the post-hepatic all will be normal, not dilated. Clear?
Yes.
Okay, so here we depends on the level of, even if it's a just normal question, and we just want to know where is the obstruction here. If he told you what is the level of obstruction, and he tell you normal caliber of common bile duct, there is normal caliber of common bile duct and intrahepatic duct dilatation, and this is normal, so the level of obstruction is at the porta hepatis. So what can make porta hepatis obstruction is the hilar lymphadenopathy. Okay, who can tell us what's Fitz-Hugh syndrome?
This is adhesions in the between the abdominal wall and the viscera following a chlamydia infection.
Viscera?
PID.
Is the Fitz-Hugh syndrome is between the abdominal wall and viscera?
Between the periton,
there is a band. Actually, there is a band from the liver to the pelvis because of the pelvic inflammatory disease.
Okay. This is all right. Hypochondrial pain due to perihepatic inflammation and fibrosis, fibrinous adhesion, concomitant with pelvic inflammatory disease in the female in PID. So sometimes the patient come with vaginal, and we have many scenarios in the last 2 sessions, and we said the patient come with vaginal discharge and have a right hypochondrial pain. What's your diagnosis? Fitz-Hugh syndrome. And another one came with the same symptoms and ask about what is the diagnosis, which is PID. So whatever, vaginal discharge is associated with PID and transmitted infection to the perihepatic space causes what's called Fitz-Hugh syndrome. Okay? Is it clear what's Fitz-Hugh syndrome? Perihepatic fibrinous adhesions associated with PID in females, and the scenario will come female with pelvic pain and vaginal or right iliac fossa pain and right hypochondrial pain with vaginal discharge. Pregnancy test is normal, and ultrasound of the pelvis clear, or last menstrual period normal, and the patient pregnancy test or beta HCG is normal. This is the scenario of Fitz-Hugh syndrome. Okay, next question, Dr. Az.
A 59-year-old man is diagnosed as having a carcinoma of the pancreas with 2 malignant deposits in the right lobe of the liver. What is the most appropriate treatment? Palliative chemotherapy, liver resection followed by chemotherapy, simultaneous resection of liver metastasis and in-block segmental pancreatic resection, pancreatic resection followed by liver resection once recovered, radical radiotherapy followed by surgery. Simultaneous resection of liver metastasis and in-block segmental pancreatic resection. He is not too old. He's 59 years old.
Okay, anyone has different answer? Nishad. Dr. Abu Yazid say A, Dr. Fad A, Dr. Shi A, or go with palliative chemotherapy. Okay, any metastatic pancreatic tumor, so once it's relieved, it arrives the liver, so for sure it metastasized to other organs in the body. So metastatic pancreatic lesions, metastatic tumor is palliative treatment, palliative chemotherapy, and surgery will be difficult and he will be unfit for surgery for irresectable tumor. Okay, whatever many metastases or 2 metastases, this will be mostly you have to make a metastatic workup for all the body with PET scan to make sure that it's only the liver, and this will be mostly impossible. Okay, so whatever it's multiple or 2 metastases, you will go for palliative chemotherapy. If the patient is obstructive and jaundice, you will go for a stent only as a palliative treatment as well. Okay, Dr. Basharat.
A 34-year-old lady is admitted with jaundice and undergoes an ERCP. The procedure is technically difficult and she is returned to the ward still jaundiced. Unfortunately, she now has severe generalized abdominal pain. What is the best course of action? Arrange abdominal MRI scan, arrange MRCP, arrange an abdominal CT scan, undertake a laparotomy and biliary bypass. Jaundice and...
What do you expect for this patient? What happened?
Definitely there is obstruction, so there is jaundice.
Patient come after ERCP.
Yes, there is difficult ERCP. We will go for
still jaundice,
laparotomy.
Still jaundice and has severe abdominal pain.
General abdominal pain. That means there is peritonitis already now.
Yes.
Maybe pancreatitis as a side effect from ERCP.
So one said maybe pancreatitis, one said maybe injury, some said no, some perforation. So what's the best action for this?
The best here to do CT abdomen.
Yes, exactly. We want to diagnose what happened. The most common what happened is injury for the common bile duct, the pancreas, the duodenum. Okay, because the patient, you didn't relieve obstruction, so, and it was technically difficult. So some injury has happened inside. How to diagnose this injury for the pancreas, or if I did MRCP for the liver only, and if I have a problem in the pancreas, it will be difficult. And I need to do some contrast imaging. So I'll go for CT scan with contrast to detect where is the injury, and maybe I induced pancreatitis, bile duct injury, or duodenal injury. Okay. Next question. Why not laparotomy? I already did investigations through ERCP. No. I have failed ERCP. The ERCP failed, and the patient come back to the ward still jaundiced and have severe abdominal pain. So I just want to do, because if it is pancreatitis, while if I did an exploration and find it negative and it was just a pancreatitis, what will you do? Nothing. You have to make sure that is away, because pancreatitis is a common injury within through the ERCP. So you have just to take care and make good diagnosis before you go for any intervention. Okay, yeah. Next one, Dr. Shi.
A 58-year-old woman is admitted with an attack of severe acute pancreatitis. She's managed on the intensive care unit and is making progress. She then deteriorates, and a CT scan shows extensive pancreatic necrosis, more than 40%. There are concerns that this might have become infected. What is the correct course of action? So, A, undertake a fine needle aspiration of the area.
Okay. No, a different answer. Dr. Abul Yazid B, Dr. Az B. Yes, undertake a fine needle aspiration. No, before we go for necrosectomy, I have to make sure this is what is a necrotic tissue? Is it infection? So I have to go through, or just some necrosis and some hemorrhage, and I can't go through. This is the scenario we do for pancreas. I have problem in the pancreas, I go for ultrasound or CT. Okay, it is revealed some necrosis. I go for fine needle that okay, I go for fine needle. If it is infection and proved source of infection, I can go for necrosectomy. Okay, so I have to go these steps in pancreatic necrosis or necrotic tissue. Clear?
Yes.
Okay, next question, Dr. Zaina.
Okay. 41-year-old lady with colic right upper quadrant pain, identified as having a gallstone on an abdominal ultrasound scan. What is the most appropriate course of action? Laparoscopic cholecystectomy, open cholecystectomy, liver function test, MRCS, ERCP. هي دي جول بلادر ستون فهيحتاج cholecystectomy. تمام. But we can't do cholecystectomy without liver function and bilirubin.
Okay, yes.
So I don't know
exactly.
to choose
C.
A or C.
No, exactly C. Any patient come for you, any patient come for you in the ER or in your clinic, and you did ultrasound his right upper quadrant abdominal pain, and you find he has a problem like gallstones. First thing before preparing him for operation or for something like this, you have to do liver function test to make sure that the liver function is still normal. So he is fit for surgery and don't need any further investigations before going for laparoscopic cholecystectomy. So this is just a step like the last one we said about the pancreatic necrotic tissue. We have to do fine needle to make sure that there is no infection or about the infection. And the other thing here, the same with ultrasound. Another scenario will tell you we will face soon, and he will tell you that we did an ultrasound and we found stones, and then we did liver function test, so it is normal. And so he will ask, what is your next step, which will be what?
Lab cholecystectomy.
Lab cholecystectomy, exactly. So this is some steps, we will go easy, so just get used for it, okay? Next question. Dr. Az.
A 34-year-old lady is undergoing a laparoscopic cholecystectomy for cholecystitis. She has been unwell for the past 10 days on attempting to dissect the gallbladder, which is distended. All that can be seen are the gallbladder fundus, and dense adhesions make it difficult to dissect Carlot's triangle. What is the best course of action? Perform an operative cholecystostomy, dissect the adhesion of Carlot triangle and continue with the cholecystectomy, dissect out the bile duct and perform a cholangiogram and ERCP, arrange a BTC. A. Perform an operative cholecystostomy. نفتح كده ونفضيها. تمام؟
Okay. Anyone has a different answer?
No, the same. A.
Okay, this is a case like empyema with the gallbladder, and he tell you the gallbladder is distended, and you are with a trial, and she is. By the way, this is a typical picture with a patient with acute cholecystitis, and after 10 days, and sometimes you have to good diagnose this patient before, because the patient may not be fit for surgery, okay? Maybe not fit for surgery. And some patients, we do cholecystostomy percutaneous under ultrasonic guide or MRI or CT. If you found this patient, if this patient is represented with acute cholecystitis, and she is represented after this first golden days or the golden time for surgery, which is the first 48 to 72 hours, okay? This patient should be not fit for surgery, but the patient has a distended bladder. Maybe the patient is toxemic or have fever and something like constitutional symptoms of infection. And what will you do this patient? Sometimes we go for percutaneous cholecystostomy through ultrasound, and we put a catheter, sometimes like polycatheter or some sort of catheter. We put it in the gallbladder to evacuate and prepare the patient for interval cholecystectomy. But here the doctor started to do the operation after 10 days. And that's why he found there is adhesions of the gallbladder fundus, and there is distension of the gallbladder, and he pushed to do intraoperative cholecystostomy. Okay, this is a case of doing an operation after the golden time for management of acute cholecystitis. Is it clear?
Yes.
Okay, next question. Who's there? Dr. Basharat, تفضل.
A 63-year-old man is admitted to the ITU with an attack of severe gallstone pancreatitis. He requires ventilator support for acute respiratory distress syndrome. Over the past few days, he has become more unwell and a CT scan is organized. This demonstrates an area of necrosis. Culture from the area shows a gram-negative bacillus. His CRP is 400 and WBC is 25.1. What is the best course of action? For here, definitely there will be pancreatic necrosectomy because necrose CT scan is done, culture has been taken, so all the procedures have been done, so we'll proceed for the pancreatic necrosectomy.
Exactly.
Diagnosed.
So we get our ladder for good ladder for procedures. In UK, they don't like to go for a step missing a previous step or another step. So ultrasound or CT, so there is necrosis, do fine needle, there's infection, do necrosectomy. Okay. This is what is like to do in UK. Perfect, Dr. Basharat. Okay, next, Dr. Shi.
A 41-year-old lady is admitted with colicky right upper quadrant pain. On clinical examination, she has a mild pyrexia and is clinically jaundiced. An ultrasound scan is reported as showing gallstones, and the patient is taken to theatre for an open cholecystectomy. At operation, callous triangles is almost completely impossible to delineate. What is the most likely explanation?
Callous triangle is most completely impossible to delineate. Okay.
Yeah. So,
what do you think what happens here?
syndrome.
Okay, do you know what's Mersey syndrome?
It's when you have the stone which is stuck in the Hartmann's pouch or the cystic duct which obstructs the common bile duct and the hepatic duct, causing the jaundice.
Perfect. And this is what the patient, mild pyrexia, jaundice, and this jaundice. Is what the presentation of the patient.
The cholangitis.
Exactly.
Cholangitis.
So the patient's coming with Charcot striate, and you went for open cholecystectomy. I don't know why he went for open cholecystectomy, but just this is the scenario that he went for open cholecystectomy, and he can't delineate the callous triangle during surgery. And so, what's your diagnosis? It's Mersey syndrome. Mersey syndrome is clear, or anyone want to illustrate?
It's clear.
Clear for all. Clear. Okay. Perfect. Next question, Dr. Zaina.
Okay. 42 years old female presents with symptoms of biliary colic, and on investigation is identified as having gallstones. All of the procedures listed below, which was most likely to increase the risk of gallstone formation: partial gastrectomy, jejunal resection, liver lobectomy, ileal resection, left hemicolectomy. Ileal resection.
Why?
عشان البايل اسيد absorption في الإليوم.
اوكي.
فلو في ريسكشن بايل سولز، لو حصل له ريسكشن مش هيحصل absorption تاني.
Okay, we will do disturbance for the normal bile constitution. Okay, which will be the cholesterol is higher than the bile salts. So this disturbance will lead to stone formation. And this is very common in ileal resection and very common with inflammatory bowel disease, which sometimes with terminal ileitis and Crohn's disease, when we do for resection of part of the bowel, or sometimes when we remove large segment from the small intestine, including the terminal ileum. We face this problem of reduced bile salt absorption, and the patient will have gallstone, and this will be one of the common complications of Crohn's disease as well. Next question.
A 43-year-old woman is admitted with acute cholecystitis and fails to settle. A laparoscopic cholecystectomy is being performed. At operation, the gallbladder has evidence of an empyema and callus triangle is inflamed. And surgeon suspects that a MERS syndrome has occurred. What's the best course of action? Undertake an operative cholecystostomy, perform a subtotal cholecystectomy, perform a laparotomy, perform exploration of the common bile duct, continue subarachnoid triangle, and to complete the operation. Perform a laparotomy.
Okay. Anyone has different answer?
محتاجة more dissection.
Subtotal. Exploration of the why exploration of the common bile duct? Okay, so you went with laparoscope and just look with the camera, and you find whitish or just light yellow gallbladder, okay, which is evidence of empyema, and empyema, the gallbladder is edematous, sometimes petechiae of pus you'll find on the wall of the gallbladder, and the callus triangle is inflamed, and the surgeon as well suspect MERS syndrome. So you have many complications with the laparoscope. Any trial for intervention or completion of the operation by laparoscope, you will 100% you'll make a catastrophe inside, because you will not be able to catch the gallbladder with your grasper, and you can't be able to dissect the callus, or can't dissect the MERS syndrome, and you may make injury to the common bile duct and hepatic duct, and catastrophe. And the best choice here is to go for operative cholecystostomy. Okay? Hello?
Yes.
Yes, clear. This is the same scenario what we happened before. This patient mostly will come with delayed presentation, or the patient give you something like not good history or missing history, and you unfortunately went for the operation. It is wise to go to complete the operation, and you have to evacuate this operation. And the same like acute cholecystitis with distended gallbladder, you just want to evacuate the gallbladder. The same if you have good diagnosis with CT before the operation, and you find this investigation and everything, you will do it by, if there is open, if there is open cholecystectomy in option. Okay, no, or subtotal, he told you MERS syndrome, that's why he told you subtotal cholecystectomy, because in MERS syndrome, you will not be able to do a cholecystectomy. It will be unwise, subtotal cholecystectomy, to do it with MERS syndrome. If you found MERS syndrome, you go for subtotal, because you will not be able to remove the Hartmann, and you will leave the Hartmann stuck to the common bile duct as one unit. But here is unwise. You will find no tissue to catch, no tissue to cut, no tissue to suture, no tissue to take your clip or suture material. What is wise here is, if you diagnose before any acute cholecystitis, if you diagnose before distended gallbladder and inflamed and the patient is not feeling well, do a percutaneous cholecystostomy. Ultrasound guided percutaneous cholecystostomy is the best choice for this patient. But we have two scenarios different, that the doctor or the surgeon inside, he discovered that he have a distended gallbladder. So he had to make a intraoperative cholecystostomy. Okay. Just take care, please.
Why not doing the cholecystostomy using laparoscope? Why have to make it open surgery, operative?
Why operative?
Which operative cholecystomy means that he will do incision, surgical incision.
He will do, yes.
Why not doing it with laparoscope?
Sometimes no. Sometimes he will not make the whole cochlear incision, by the way. Operative cholecystostomy means make an incision for the cholecystostomy bus out, only cholecystostomy is outside. So he don't need to do it operative, okay? I'm just telling you. The gallbladder is here.
Why he put in the options undertake an operative cholecystomy in option? Why put operative? And when I answered laparotomy,
excuse me, because the patient is already on the table. That means we have to go for an operative. You will not.
Yes, one of the cause you already the patient.
And then go for ultrasound. You are inside the abdomen. Just through that trocar, you put a pigtail inside and put it in the gallbladder.
No, I'm telling you, there is another option. But it will be difficult for non-surgical to do it. Okay. This had an expert person doing with laparoscope. You are already making 3 ports. So if this is the patient, okay, and this is the reps, and you're doing in the umbilicus, so you are doing 1 port here, 1 port here, 1 port here, 1 port here. Okay. If you are an expert surgeon, you will put a drain, you will make the opening, but you just you are expert. You are expert to cannulate a drain from the skin outside through this opening. Okay. And this is a drain, and this cannulate the drain inside the gallbladder without making intraperitoneal spillage.
Yes.
Okay. Sometimes we put a drain like this. Sometimes we put a drain like this. Sometimes we put a T-tube laparoscopically. Exploration laparoscopically. Exploration, and we put a T-tube. But he didn't put this option here. Yes, you can do it laparoscopic, by the way. Expert surgeon cannulate from one of the ports opening, like you are putting a drain, post-cholecystectomy, and you are putting a drain. You just untick this specific drain or Foley-Caster and cannulate it through the gallbladder without spillage or with minimal spillage, and make the balloon or inflate the balloon and fix the stent or fix the drain, and you can go laparoscopic. But it just needs some expert surgeon. And the only option he gave us here is the open cholecystostomy. So we will go for this because other options are not logic, like subtotal cholecystectomy, no. Is infection, we can do this. Laparotomy, no. Why laparotomy? Exploration of the combile duct, we don't have any problem with the combile duct. And explore the callus triangle and complete the operation, and this is the most catastrophic choice.
Okay. First choice is the safest one.
Yes, exactly. Even if it's unlogic for surgeon, if an expert surgeon read this question, like some expert in laparoscopic surgery, he will do, why operative? I can do it through laparoscopic. And
could
he's
be
right. And
guided by ultrasound.
why the patient is on the table already?
Okay, if
Why?
it's a table, we will do at the same time. But if not,
Yes, if it's not on table, yes, we will do it under ultrasonic guide. Okay, next question, Dr. Shi.
A 68-year-old man with type 2 diabetes is admitted to hospital unwell. On examination, he has features of septic shock and right upper quadrant tenderness. He is not jaundiced. Imaging shows a normal caliber bile duct and no stones in the gallbladder. What is the most likely diagnosis? So, cholangitis.
Septic shock, right upper quadrant pain,
Yes.
tenderness. He is
But
not
no jaundice.
jaundiced.
No jaundice.
No jaundice. Jaundice, so not
No jaundice. This is
cholangitis.
not Charcot striae.
Yeah.
So, normal caliber with no stones.
Acute
So-
calculus cholecystitis.
Acute acalcular cholecystitis.
So you did
maybe.
choose this one and then go, okay, we have two choices now. We choose acute acalculus and we choose cholangitis. Acute acalculus and we go for the symptoms again. Is it comes with septic shock? Maybe. Upper quadrant pain? Yes.
Yes.
Murphy's. And not jaundice? Yes. Why
Yes.
jaundice and acute
That-
acalcular cholecystitis? And normal caliber, yes. But in cholangitis, the only difference here is the jaundice.
The jaundice.
Yes. If he is jaundiced, it will change your choice for cholangitis. So this is acute acalculous cholecystitis. Just make sure this is Murphy's sign and tender. This is acute cholecystitis. But there is no stone.
And patient has diabetes as well.
Yes, and this is favors the problem, and this is the most common patients we see acute acalcular cholecystitis in them, diabetic patients. Okay.
Okay.
Next question, Rosena.
Okay. 43 years old male with long-standing chronic hepatitis is being followed up. Recently, his alpha-fetoprotein is noted to be increased, and an abdominal ultrasound demonstrates 2 centimeter lesion in segment 5 of the liver. What is the most appropriate course of action? BT, CT scan, liver MRI, ultrasound-guided liver biopsy, laparoscopic biopsy, segmental resection of segment 5. ليفر MRI بس مش هو المفروض يكون ليفر CT الأول. مش عارفة اليوم مش حاطة في الأوبشن.
Liver MRI. Why?
عشان نشوف لو في أي ميتاسيس تانية مش باينة في الألتراساوند.
Okay, this is a chronic patient, chronic hepatitis. So most commonly the patient will develop
hepatocellular carcinoma
versus regeneration nodules, and you find one nodule in this segment 5, and you are doing ultrasound. What will you do?
MRI بس يعني الأول المفروض CT first CT.
The MRI, liver, first for liver is MRI. Or sometimes now they are multi-slice triphasic CT. But still for soft tissue till now we have, I did see many doctors, some surgeons prefer to do MRI and some surgeons prefer to do multi-slice triphasic CT scan. But we don't have here multi-slice CT. By the way, if we have it here, we could choose it because he had PET-CT, not PET-CT, ultrasound, no, liver segmental resection, no. So both are right. That's why he didn't mention both options. Sometimes multi-slice or triphasic CT scan or MRI. If he found this and this, and he will never bring the two choices at the same time. Okay. Next question.
A 45-year-old man. A 45-year-old man presents with an episode of alcoholic pancreatitis. He makes slow but steady progress. He is reviewed clinically at 6 weeks following admission. He has a diffuse fullness of his upper abdomen, and on imaging, a collection of fluid is found to be located behind the stomach. His serum amylase is mildly elevated. Which of the following is the most likely explanation? Pseudocyst. So, pseudocyst. Following pancreatitis,
Exactly.
oral stomach.
Yes, six weeks and following pancreatitis and behind the stomach. And this is serum amylase is mildly elevated. Yes, mixed mild elevation in serum amylase. So this is pancreatic pseudocyst.
الحمد لله أخيرا بقينا نقول حاجة صح.
لا عليك كويس خالص زي الفل. Okay, next Dr. Basharat.
A 34-year-old lady is admitted with pancreatitis. The etiology is unclear and it is classified as an attack of moderate severe according to the Glasgow criteria. Her imaging shows no gallstones and fluid around the pancreas. No gallstone and fluid around the pancreas. Which of the following is the most appropriate initial management option? Laparotomy, laparoscopy, radiological aspiration of the fluid, active observation, administration of octreotide. The etiology is unclear still, and so we'll not go for a surgery, and it is classified as an attack of moderate severe according to. So her imaging shows no gallstone and fluid around the pancreas. So we'll go for observation for this patient. We'll actually observe the patient.
That's exactly this patient of acute severe pancreatitis. Okay, and we don't have, we just searching for the reason to the, to do, if it is a gallstone, we will go for eRCP, or it is a pancreatic mass, we will go for RCP. But we found that everything is okay. And the imaging, no gallstones, but there is edema around the pancreas. So what will we do? We'll admit the patient to ITU or ICU according to the policy of the hospital, and do active observation for the patient with the regimen for acute pancreatitis. Okay, the reason we are searching for what is the cause is to treat the cause, even if it is a pancreatic mass or a stone. But here we find nothing, so what we'll do, follow-up observation of the patient. Yes, an ITU or ICU. ITU, intensive therapeutic unit. حاجة أقل من ICU كده.
مش هي الورد يعني ولا إيه؟
لا أعلى من الورد. Between the ward and the ICU in UK, ITU.
Yes.
Put in your
All
mind.
the cases
ITU
of
is a high care.
go to the ITU.
Okay. ITU, there is one nurse for 2 patients. ICU, one nurse for 1 patient. In the ward, 1 nurse for 6, 7, 8. Okay. And ITU is a high care unit for patients. Sometimes like patient subgrading from the ICU to the ward, he can go for 1 day in the ITU.
This is actually called a step down ICU.
Yes, step down ICU. Exactly, I'm telling you, a step down ICU, and sometimes patient post-operative go for ITU and followed by the ward. Sometimes, which is the definition of it. We will have many. Yes, exactly. we will have exactly here in our countries we have an ICU one nurse for 10 patients in ICU, but there in ICU one patient for one patient, one nurse for one patient.
والدكتور عمال يقولها كتير، عامل لك اي تي يو اي تي يو كأنها حاجه عاديه كده، وانا مش عايز ارد بصراحه، مش عارف اقول له ايه.
You will find ITU. You will find ITU in part B many cases about ITU, and you will know the difference between ITU and the ward and ICU, and the criteria of admission the patient for ITU and the ward and the ICU. Okay.
Do they have ITU in Pakistan, India?
I don't know.
In
really,
private
but
hospitals, yes. In private hospitals, yes. But in government setup, some big hospitals have, not the all.
غلابة زينا يعني.
والله أنا طيب الحمد لله. Okay, good.
Okay, يلا next question. Pause.
Okay. A 63-year-old man is admitted with obstructive jaundice that has developed over the past 3 weeks. He was previously well, and an examination has a smooth mass in his right upper quadrant. What is the most likely underlying diagnosis? A. Mirizi syndrome, B. Bile duct stone, C. Carcinoma of the pancreas, D. Benign bile duct stricture, and E. Chronic cholecystitis. C. Carcinoma of the pancreas. Hello?
Sorry, I was muted. What's your explanation here? What is the mass? What is the smooth mass?
This is a carcinoma of the head of pancreas, which has is
the smooth mass in the right upper quadrant.
Causing jaundice.
Yes, this compresses the common bile duct, which causes jaundice.
On examination.
Carcinoma of the pancreas.
On examination, you find a smooth mass in the right upper quadrant. What is this smooth mass?
It's the gallbladder.
Dr. Shi. Perfect.
It's the gallbladder.
It's the same. Yes, exactly. This is what's called
distended gallbladder.
Exactly. This is what's called Courvoisier. This is French. Courvoisier law. This is French name, by the way. Courvoisier. Yes, exactly. It's written here. Courvoisier law, and Courvoisier law tells you if you found a patient with jaundice and clinically you want to know what is the problem with this patient, and obstructive jaundice. Sorry, a patient with obstructive jaundice. Okay, we have 2 patients with obstruction, one with stone and one with cancer head of pancreas. Why here the gallbladder is distended and why here the gallbladder is not distended? This is the idea of Courvoisier law. Anyone has explanation? Okay. Stone cause fibrosis. Yes, chronic cholecystitis will cause chronic fibrosis and chronic stricture. Yes, exactly. Chronic fibrosis and chronic inflammation with fibrosis, and the wall of the gallbladder will lose its elasticity by time, and as the stone passed here and obstructed the common bile duct and here the stone and obstructed the common bile duct and the cystic duct, Actually, here it is full and distended, but it will not make a large ball because it lost its elasticity. But here, the acute problem or the problem that happened extra the gallbladder with the pancreatic mass, it will obstruct the common bile duct and the cystic duct, and there is a collection here which will distend the gallbladder, and it is still healthy and elastable, and the elasticity is good, and so it will distend like a balloon, and you will feel it like distended mass, smooth mass with hand examination. Okay, you get the idea?
Yes.
Clear?
Clear.
Okay. So here is carcinoma of the head of pancreas. Just put smooth swelling in patient. If you feel the swelling with jaundice, so it is carcinoma. If you didn't feel the swelling, it most probably will be a stone due to chronic calcular cholecystitis. So it will be a stone condition. Okay, go, Dr. Shi.
A 43-year-old lady presents with an attack of acute pancreatitis. It is classified as a mild attack on severity scoring. Imaging identifies gallstones, but a normal caliber bile duct and a peripancreatic fluid collection. Which of the following management options is most appropriate? Gallstone. So, a nasogastric drainage of stomach, C.
Why?
To decrease the reflux of acid over the pancreas to minimize the pancreatitis effect.
But is the
We
acid...
have to keep patients NPO. We have to keep patients
Wait,
NPO.
is the patient, is the cause of pancreatitis, is the reflux of acid?
No.
Reflux of bile.
Yeah, of bile.
Yes. What happened here for this person, for this patient?
So most probably one of the gallstones maybe has passed through the CVD and then has caused the pancreatitis, or maybe due to the recurrent
a stone passed.
Yeah.
Okay. A stone passed, and during its passage, slow passage, till it is released here, make back reflux of pancreatic fluid and some bile, and makes attack, a mild attack of acute pancreatitis. So this patient, the patient who passed one stone and passes an attack of acute cholecystitis, acute calcular pancreatitis, acute calcular or acute pancreatitis due to calcular cause or stone passing, this patient is susceptible for many attacks because already the stone could pass, so the cystic duct is open and wide, and the opening through the common bile duct is wide. So as the patient passed one stone, he will fortunately will pass more and more stones. So this patient, you will go for cholecystectomy as the attack settles to prevent recurrence of these attacks. Okay?
Oh, okay.
Get the idea?
Yes.
Next question, Dr. Zena. Dr. Zena. Okay, Dr. Az, go.
A surgeon is undertaking a cholecystectomy for cholecystitis secondary to gallstones. The operation is difficult and the views of callus triangle are poor. Unfortunately, the distal aspect of the bile duct is transected. What is the most appropriate course of action? Perform a primary suture repair a defect over a T-tube, place drains and close the wound, scout with hepatobiliary surgery. I choose C. Repair the defect with C. Place drains and close the wounds and scout with a hepatobiliary surgeon, because who was the one is taking the operation was a general surgeon, and I think it's need an
Yes,
expert
exactly.
hepatobiliary surgeon.
Any hepatobiliary problem, just run for your life and refer the case for a hepatobiliary surgeon, okay, or hepatobiliary center, because any attempts to repair will make a more catastrophe and more catastrophe. Okay, this was my my essay and my master degree, by the way. So how bile duct injury, and you should never ever interfere. You should refer it for a hepatobiliary surgery or hepatobiliary center to do. So just put a drain and close your wound and refer the patient. Be safe. Okay, next question. Dr. Basharat.
A 43-year-old lady with repeated episodes of abdominal pain is admitted with small bowel obstruction. A laparotomy is performed, and at surgery, a gallstone ileus is identified. Which is the most appropriate course of action? This is
what will you do?
question
Without reading, what will you do for this patient, Elias?
Yes, remove the gallstone, remove the stone, and keep the gallbladder.
Remove the stone through a proximal incision and leave.
Yes.
Which
and
one?
Keep the gallbladder.
D?
D, exactly.
D.
What? No. Enterotomy at the site of obstruction. Not at the site of obstruction, at proximal site. A.
Yes, at the proximal site, sorry.
Proximal site. We said the
Remove
answer.
the
We make proximal, not at the site of entry. Not take care, not at the site of obstruction. Not at the site.
No, not at the site of proximal. Proximal to the
proximal site.
Proximal sited.
Proximal site. It is dilated because the stone already passed, so it is wide enough. You don't know what is the distal. It is wide or not. Site of obstruction itself may be thinned. It may be inflamed. It may be some damage or ischemia. So don't try to make an incision and suture it, because mostly a fistula will happen through this site. Okay, so just keep it away and leave the gallbladder. Why leave the gallbladder? Again, we explained it in the start of the video. You have to leave the gallbladder inside too, because it makes a fistula with the duodenum. And you don't try to interfere. It's very hard to repair. Okay, exactly. Very hard to repair the duodenum. So you have a patch or a normal cover for a duodenal fistula. Don't try to interfere. Okay, next question. Dr. Shi.
A 42-year-old lady presents with right upper quadrant pain and a sensation of abdominal fullness. An ultrasound scan demonstrates a 6.5 centimeter hyperechoic lesion in the right lobe of the liver. Serum AFP is normal. What is the most underlying lesion? I think it's hyperechoic hemangioma, B.
Yes, exactly.
Is the hemangioma painful?
No, not necessarily.
Sometimes.
Yeah.
Sometimes, but you can discuss, and this is not painful. But sometimes discomfort, but it's not painful. Sometimes some discomfort if it is large in the liver. Next, like some stitching pain, some discomfort pain when it is outside and peripheral and pushing. Fullness sensation if it is pressing on the viscera, on the visceral peritoneum. okay, on the serosa, so it makes this pain. Other than this, it is painless. Okay, so just make sure that is hyperechoic means high vascularity. So it may be hepatocellular carcinoma or metastasis or hemangioma, but he tell you serum alpha-fetoprotein is normal, so we exclude carcinoma and mets, and it will be a hemangioma. I think adenoma will be hypoechoic. Okay, I think so. I'm just may read it in the recalls. But hyperechoic means the vascularity is higher, so it is hemangioma. Or carcinoma or mets, and this depends on the alpha-fetoprotein. And the cyst will be, he will tell you a cystic lesion. Next question, Dr. Zaina Afridi. Dr. Zaina. Okay, Dr. Az, تفضل.
Following an uncomplicated laparoscopic cholecystectomy, a patient is found to have a bile leak. An ERCP is performed and leakage is noted from the cystic duct. What is the most appropriate course of action? Undertake a sphincterectomy and place stent in the common bile duct, undertake laparoscopy and place tube in the bile duct, start the patient to be in, keep them nailed mouse, transfer the patient for body bypass procedure, place a transhepatic bile stent. Start the patient leakage noted from the cystic duct. Start the patient on TBN and keep them nailed by mouse. No.
No.
No, I don't know the answer.
Okay, we said it in the first few questions. We said after the operation, you find leakage. What will you do? You'll do an ERCP. It is diagnostic, and at the same time, it may be therapeutic. If you found a small lesion, yes. If you found a small lesion, you can manage it with a stent. So you will decrease the leakage and permit for further management or spontaneous closure. Okay, you put a stent. But if you found the injury is big, so a stent will not be, you may be found like 2/3 of the caliber or high cut in the common bile duct or hepatic duct or complete transection sometimes happens. All this will make you go for definite intervention. But if you just found just the stump of the cystic duct is only leakage, that can be managed with stent. So you will decrease the leakage and at the same time permit the normal pathway of the bile through the common bile duct. Okay? Clear?
هو هو عمل كوليستكتومي خلاص.
خلص cholecystectomy and after the operation he find leakage. He find leakage.
جاي منين البايل بقى؟ جاي منين البايل؟
من الcystic, from the cystic.
Maybe clip is dislodged. Maybe clip is dislodged, maybe not is dislodged.
Exactly. Okay, he did the cholecystectomy. And we have this one. And he just ligated this. Maybe the ligature is weak. Okay. Or the ligature
maybe
is
there
slipped.
is a stone in there is called balloon syndrome.
Slipped. Happened like slip or it is not competent, and he found leakage from here. What he will do, he will put a complete stent here to make the bile go like this, and this will close spontaneously. But it depends on the amount of leakage, by the way. So if the amount is big amount, no, you have to interfere to re-explore the patient or go put another clip or something like this, or refer the patient to hepatobiliary. But if you just found small leakage, you just go for a stent. So you would make the bile pass here, even if a small amount pass here, like you are putting the T-tube, and you will close spontaneously within I think 2 to 3 days. Clear?
هي البايل بتيجي منين يا دكتور رامي؟ مش هي بتيجي من الجول بلادر؟
البايل بيجي من الهيباتيك داكت، الهيباتيك ويتخزن في الجول بلادر.
والبايل والجول بلادر بتطلع ايه؟ بايل سولز.
الجول بلادر بتطلع ايه؟ again easy.
خلاص انا فهمت قصدك. يعني السورس اوف بايل مش جاي.
بايل بيتخزن هنا. احنا this is the storage of bile and we now cut this, but our ligature or our clip is weak, so the bile coming here, passing here and passing here, so there is leakage about 5 or 10% from the bile coming here. You get it? There is leakage here. There is leakage coming from here. Clear?
Clear, Doctor.
Clear, or you need more clear? Bile coming from the liver, unless it's stored here, go directly here. But here we make a cholecystectomy and ligate it. But it is a weak ligature, or it is a slipped ligature. After I make the clip fell down. And so the bile will continue to leak from this stump, coming here, leak here, and some will go here. And so I have to just put a stent.
Yeah,
to
I got
all
it.
The bile come here. Okay.
Yeah.
Next question. Okay, doctor.
A 43-year-old lady presents with jaundice and is diagnosed as having a carcinoma of the head or pancreas. Although she is deeply jaundiced, her staging investigations are negative for metastatic disease. What is the best method of biliary decompression in this case? ERCP with sphincterotomy alone, ERCP alone, ERCP and placement of stent. ERCP with placement of stent.
Exactly. The patient, this is an emergency treatment for the patient for relief of jaundice, for further investigation and definite management. But here, staging investigation, negative for metastatic disease. So this patient, you will go for a stent and you will prepare the patient for Whipple operation.
Yes.
Okay. So stent is the option of biliary decompression, resectable disease. Surgical bypass have no place.
Sphincterotomy is for
sphincterotomy if there is a stone, to just dilate the way for the stone.
Sphincterotomy is for the duodenal sphincter.
For sphincter of Oddi.
Duodenal sphincter.
For the yes, the sphincter. The what's called?
The sphincter of Oddi.
Yes, sphincter of Oddi, exactly. For the sphincter of Oddi, you make like it is a spasm. It has a circular muscle spasm. You just make it cut so it dilates, so it allows the stone to pass. Okay, just relax for the muscle to let the stone pass.
Okay.
Next question, doctor. She.
A 34-year-old woman is admitted with cholangitis. Her bilirubin is 118, alkaline phosphatase is 348. She becomes progressively more unwell and develops abdominal pain. The F1 checks her mileage, which is elevated at 1080. Standard treatment is initiated and her Glasgow score is 3. What is the most appropriate course of action? So, ERCP.
Sorry.
ERCP.
Search for admit for conjunctivitis, proven
But it
high,
ERCP or
high,
PTC? Yeah, because
progressive and when develop abdominal pain. One checks amylase is elevated at كذا. Standard treatment is initiated in the drugs. Correct. What's the most appropriate action?
so maybe PTC because she already has pancreatitis. The amylase is raised, and she also needs to get a stenting done, but it's done only ERCP here, so maybe it's PTC.
Oh, exactly. We'll go for ERCP. Sorry, I just was answering one of your friend's question. Yes, we are no. Don't go for PTC. Don't go for PTC without passing Urology. This is a case of obstructive cholangitis together with obstruction of the. This is obstruction here is in the ampulla of water. Is in the common bile and pancreatic duct. So you will find the cholangitis and liver enzymes or bilirubin and alkaline phosphatase are high, and at the same time you will find the amylase is high because there is obstruction of the common on the common bile and the pancreatic duct. So you will go for ERCP so you can make release of the problem. The obstruction here is in the common.
Oh, sorry.
Yes.
Yeah, the common bile duct.
But
yes, in both of them.
It's here. It will be diagnostic.
The obstruction is here. Sorry.
Yeah, it would be for diagnostic also.
The ERCP here.
Huh?
Why diagnostic?
Yeah.
Now you have an obstruction. You have the patient is coming with cholangitis, high bilirubin. This is obstructive jaundice. Alkaline phosphatase high, obstructive jaundice because of cholangitis. Okay, and alkaline phosphatase is high in post-hepatic obstructive jaundice. And so now the common bile duct is obstructed. Then he went for the amylase to check is the obstruction is in the common, is the obstruction is in the common only, or in the common bile duct CBD only, or in both the CBD and pancreatic. Okay, so all investigation here are finished, and this is obstructive jaundice. And then he went for amylase, which is elevated, means the obstruction is a stone here or here.
In the distal CBD, in the distal CBD.
Distal. So you'll go for ERCP, whatever, what will you do? You'll put a stent, sphincterotomy, and remove the stone. Try to decrease the obstructive jaundice. You have a case of obstructive jaundice, and this is an emergency treatment. Whatever the patient is, stone or cancer head of pancreas and coming with jaundice, you will go for ERCP for relief. You will not leave the patient with jaundice. But it depends, what will you do further? If it is a stone and you remove, so it's okay. If it is a cancer and you relieve the obstruction, so you have time to further investigation and further evaluation of the patient for definite treatment. Whatever will go for palliative treatment. So like the answer we said before, ERCP with palliative chemotherapy. So the patient is unoperative, or ERCP and prepare the patient for Weibel's operation. Okay.
And BTC is not therapeutic, not relieving the obstruction.
PTC, you do it when you fail to cannulate the duodenal ampulla of water, the duodenal sphincter. When you fail to go with ERCP, the other thing is PTC, and as I told you, PTC is not preferred because it is frequently dislodged and frequently makes displacement from its site, and frequently the patient loses it, and you have to do it many times. So ERCP will be the best choice first, and through putting a stent, whatever, a metallic or plastic stent for relief of obstruction. Failed, when he tell you failed ERCP in patient critical with jaundice, okay, so you have to relieve the obstruction, so we will go for PTC. Okay, clear?
Clear.
Clear? Okay. Next question. Who's there?
Dr. Zena.
Dr. Zena, ready? Okay,
Okay.
go.
A 22-year-old teacher is admitted with severe epigastric pain. Severe amylase is normal. A serum amylase is normal. You wish to exclude a perforated viscous and determine whether pancreatitis is present. What is the best course of action? Order an erect chest X-ray and plain abdominal fan. Request an abdominal ultrasound. Request a CT scan of the abdomen and pelvis with intravenous contrast. Request a non-contrast CT scan of the abdomen and pelvis. Request a magnetic resonance cholangiopancreatography scan. I'll go with abdominal ultrasound. We start with simple.
Okay, this ultrasound will show you if there is a perforated viscous or no.
No اللي هي الاكس راي عشان نشوف لو في multiple fluid level. معلش انت عارفين ان انا urology
Okay, is the X-ray can exclude it is pancreatitis or not?
No, we have to go for the CT with the contrast will show both of the following.
Okay, now he tell you I want to go. The patient has severe epigastric pain, and I don't want to take the patient to the X-ray, and from the X-ray to the ultrasound, and this is a severe epigastric pain, and you just will do with one investigation to make sure to exclude perforated viscous and whatever pancreatitis is present or not. So now we have CT, okay, cholangiopancreatography, E, no, and A, X-ray or ultrasound alone, no. So we have CT. It is with contrast or without contrast?
With contrast.
Exactly, with contrast. You are going, no, with contrast. With contrast. Is there is pancreatitis or not? So you are searching for the vascularity. With pancreatitis, you will say increased contrast, intravenous contrast. Intravenous contrast. He is precise and he's keen to write intravenous contrast. He didn't write, yes, Dr. Mumtaz, okay. You are right, we can't do an oral contrast, but he's here, he said with intravenous contrast. So we can see any inflammation in the pancreas, and at the same time, we can see if there is pneumoperitoneum or air under the diaphragm. Okay? Next question, Dr. Shi. Dr. Basharat. Okay, one Dr. Shi and one Dr. Basharat. This is the last two questions. Dr. Shi, go.
Okay. What proportion of patients presenting for cholecystectomy for treatment of biliary colic due to gallstones will have stones in the common bile duct?
10%. Just a standard 10%? Percentage. Yeah, standard incidence they found with many researches and with many that people's or patient went for cholecystectomy, missed stone will be about 10% or less than 10%. Okay, and you can't find, by the way, and this is some unpredictable proportion because you will not do ERCP for all patients or MRCP. Just you'll do liver enzymes and it find this normal, maybe small stone, and so you can't find it. So 10% is just a percentage you have to know. Okay. Last question, Dr. Basharat.
Which of the following is false during the preoperative preparation for surgery in pancreatic cancer? A, IV antibiotics should be given intraoperatively. B, endotoxemia can be reduced with lactulose. C, subcutaneous heparin should be avoided. No, there should be given. This during the preoperative following is false. I think C is false.
Yes, exactly. This is a very
Because we
long
have to give
operation. Yes, you have to heparinize the patient. So subcutaneous heparin is regularly given for patient before pancreatic surgery, whatever pancreatectomy or Whipple operation. So this is the false answer. Okay. We finished hepatobiliary section of the special paper 2. Thank you, and I'll close the record.
Thank you.
And if anyone has any question, we will discuss.
Thank you.